My name is Ayaz Haider. I am the principal investigator for this ISPU study. I am also an associate professor at The Ohio State University, and I also work as the data and integrations lead at Smart Columbus. This report will be useful to those who would like to take a systems view of the problem of access to healthcare, and they would like to embark on a journey to solve those problems through a systems lens.
It's really important when you read a report like this to appreciate what it's not saying. And what it's not saying is that there's any one silver bullet. There are no silver bullets. If you want to understand how to solve a problem, it's not really about any single solution. It's about how these solutions hook together in ways that make them greater than the sum of their parts. We need to be asking what needs to be built anew, and how do we target those opportunities to disrupt feedback loops that are dangerous and promote feedback loops that are virtuous.
Community-based system dynamics was used in this study because we were focused on the role of access to healthcare among minoritized Muslim populations in Southeast Michigan. For example, if we have a group of organizations who are working to address racism and discrimination in the healthcare system, that's great. They should continue to do that work. But if they're not keeping tabs or coordinating with whoever is trying to address the social determinants of health, or someone who's trying to address how public health and healthcare system factors are affecting the trust of patients in the healthcare system, what's going to happen is you're going to have two wheels of a car turning, but not the third and the fourth. The problem of access is very broad given how many different dimensions there are to access. It can mean affordability, it can mean having health insurance or not. It can mean transportation. Are you able to get to that healthcare provider? And so given this wide range of or dimensions of access, we wanted to use a method that took a systems approach to addressing this problem in the Muslim community.
In the academy and in science, we tend to use the calcified, proud, but calcified language of the academy. We also, in the last, especially preceding decades, tend to use the commodity-driven language of science. I think that what we all need to do is, while this brilliant work by ISPU is producing data that's helping to advance science, we also got to make sure that that data is salient to the public that we serve.
If the community simply wants to identify what are the parts of the larger system that are leading to this problem happening day in and day out, we can take this approach and just give them a causal loop diagram that helps them see what those parts are. If the community is interested in going further and saying, okay, we have a diagram of how these different parts are connected, now what can we do about them? We have money, we have $1 million to spend on this problem. Where do we put that money? Well, this approach can then go further and develop a simulation model, a what-if policy simulation model that can help them identify the optimal allocation of limited resources. For me to be able to apply this approach to the Muslim community was the biggest motivator for me. I wanted to see, is this approach called community-based system dynamics applicable to communities with limited resources, communities who are facing discrimination day in and day out? Other communities outside of Southeast Michigan can definitely replicate this research. What it requires of them is a collective need, a collective vision of why this approach might be appropriate for them. This approach is appropriate for those communities who seek a whole of system change to address complicated problems within their community, whether it be Islamophobia, whether it be access to healthcare, or whether it be food insecurity or substance misuse and mental health topics. What it will take for those communities to replicate this approach is a facilitator with experience in this kind of approach. They will also need buy-in or a local champion from their community who is willing to see this project through.
And imagine if this little small ripple of water can spread across our society. Muslims in Michigan have unique health attributes that should be studied. And what you're going to find out is that they have some of the same problems everybody else does, but they also have unique problems. And if we can solve those unique problems, we can take that approach and apply it everywhere else.
We are in a unique position to apply these approaches because, especially in a place like Dearborn or Southeast Michigan, other communities do not have the resources or the capacity or the willingness to do this kind of work. You do over here. And I think there's only like a handful of communities I can count on my hands that can do this kind of work.
When we engage these studies and when we engage our communities, we have to be conscious of the history. Sometimes we have to review it. Sometimes our language has to change.
Every single patient has a different story. And for me, that's the meaning behind the work, is when I sit across the patient and hear their story first, it kind of brings you to be able to, serve them at a better lens. And most of the times it's stories from patients that are from the similar background from us. And that's what this research is about. For me to be engaged in this work, it came down to how do I enable myself to support the work that's focused on not only healthcare, but our specific community. And what this research does is takes all these stories and identifies the barriers within these stories and tries to come up with recommendations and solutions, as Dr. Hyder mentioned, to possibly address these barriers that are limiting in every individual stories.